Hi. Hi, so today's lecture is about RV, nothing but retinoblastoma. Very easy, very simple, basic stuff. Well, let's just directly jump into it. Retinoblastoma is the tumor of the retina. Retinoblastoma is the tumor of the retina. It's usually seen in age less than 3. It's one of the most common cause of unilateral leukocoria. One of the most common cause of bilateral leukocoria is a cataract. And remember that leukocoria is also seen in toxocoriosis. RV is basically retinoblastoma, where leukocoria is obviously seen. What is the double hit hypothesis when they ask about the pathogenesis? Well, there is an RB gene. RB gene is what? Retinoblastoma gene is a tumor suppressor gene. A tumor suppressor gene is retinoblastoma. It actually binds to E2F protein, and it basically this EF protein is a proto-oncogene, so it inhibits a proto-oncogene. Well, so basically what happens is that this retinoblastoma, when has a single hit, that means there is a mutation, and there's a suppression mutation where the tumor suppressor gene is inactivated. That is a single hit, and usually a single hit may be present, may not be present, but definitely a double hit is needed. That means both the retinoblastoma gene must be absent from a person's body in case for that person to develop retinoblastoma. So definitely this gene is something that is autosomal dominant, and therefore genotypically it comes as a question that is this gene autosomal dominant? Yes, it is autosomal dominant, but autosomal recessive is when you talk about it phenotypically. That means both of the genes must be deleted, must show a defect for a patient or a person to develop retinoblastoma. So that is a very important point. Second is that there are two types of retinoblastoma. The tumor itself, it can be an exophytic or an endophytic, and that depends upon the direction of its growth. Well, what do you mean by direction of its growth? Well, let's say if the tumor grows posteriorly into the lamina cribrosa and into the optic nerve, so that means exophytic. And exophytic is very bad. It shows bad prognosis, number one. Second is that it invades the laminosa cribrosa. Okay, so laminosa cribrosa is that scleral area with a lot of holes, like net-like scleral structure through which the optic nerve exits, and obviously it can compress the extraocular muscle to actually cause something called as ptosis. Obviously there is another type which is the endophytic, which actually grows into the vitreous, and it is can be seen on a beta scan USG of the retina, and obviously shows calcification to give a cortices appearance. All right, so those are the two types of retinoblastoma based on the structures. Okay, so that is about the structures. A very important sign that you should keep in mind is that it can lead to leukocoria. Number one, it can lead to leukocoria, basically the bite reflex on ophthalmoscopy. All right, and second is that it can also lead to very important a very important second common sign, which is actually squint or strabismus. All right, it can cause strabismus, and also it can cause secondary glaucoma. Secondary glaucoma, okay, because of the tumor seeding. Let's say if the tumor grows endophytically and goes into more towards the aqueous chamber and detaches, so it can cause one of those, and can also cause ophthalmos, which is enlarged eye. Ophthalmos, when the eyeball is enlarged, basically. All right, so that is another very important clinical. Those are the clinical features of retinoblastoma. Some other important points where leukocoria can be seen, as I spoke about retinoblastoma, cataract, toxocoriosis. You should also keep retinopathy of prematurity in mind, and you should also keep a very important cause as coloboma of the choroid, and pseudoglioma, and coloboma of choroid. Actually, it's not very important, but just to keep as a DD, and just for completion's sake, I'm putting these two. All right, let's get back to H&E. What about the H&E of this entire? It can come as an H&E. Actually, they are small, round. Okay, they are small, round. They are blue in color. Okay, okay, blue cells. Okay, plus large nuclei. Okay, and they have something so they have some very important point. One is the Honorite rosette. Second is the necrosis and calcification, as I've already spoken, as in the endophytic calcification. And very important is the flexor winster. All right, flexor winster rosette. Flexor Winster rosette. Okay, these Honorite rosettes are seen in a lot of cases, like a medulloblastoma can also show, neuroblastoma can also show a Honorite rosette, and flexor Winster rosette is something which is very pathognomic. So you should remember flexor Winster rosette. All right, that's about the retinoblastoma. H&E diagnosis, you should know CT calcification, MRI you could see for the metastasis, posterior metastasis, exophytic retinoblastoma metastasis, biopsy you want to check for H&E like Honorite, flexor Winster, and necrosis and calcification. Treatment of choice is enucleation plus CEV is carboplatin, etoposide, and vincristine. Carboplatin, etoposide, and vincristine. Okay, remember that first. So basically you grade the tumors, grade 1, 2, 3, 4, 5, basically on the amount of volume that it occupies, if vitreous hemorrhage is present or not, and stuff like that. The only thing you should remember is that what is grade 5? Grade 5 is when hemorrhage is present. Okay, hemorrhage is present, it involves greater than 50% mass. Okay, and rubeosus iridis is seen. Now the major reason rubeosus iridis can actually also cause a secondary angle closure glaucoma. Okay, angle closure glaucoma. Rubeosus iridis also seen in retinopathy of prematurity and a lot of different conditions. Any condition where there's macular edema, or where there's release of where there is hypoxia and then subsequent release of angiogenic factors. So obviously grade 5 is where you treat by enucleation. Grade 2 is where you treat by carboplatin and vincristine, carboplatin and etoposide, vincristine in grade 3 and grade 4. So those are almost the same, and this is about when we are talking about retinoblastoma. I think that is about it. Just very important to note is that where else can you see Honorite rosette, because this comes as a neurological neuropathoma. MCQ is that where you can see it as neuroblastoma. You can see it also in Ewing sarcoma, Ewing sarcoma, and I also feel that you can also see it in a medulloblastoma. There is another. The only question is, can you see it in a medulloblastoma or astrocytoma? But astrocytoma is actually a GFAP positive tumor, so I do not think that you could see it in an astrocytoma. But if you spare me another 30 seconds, I think I can figure that out if it is seen in any of the CNS tumors. Obviously, definitely not in the oligodendrogliomas, because there will be a chicken wiring and calcification. So that definitely is ruled out. The only one that's left is medulloblastoma, and obviously your gliocytic astrocytoma or a pilocytic astrocytoma. But that is only the thing that we need to check. Pilocytic astrocytoma actually shows a lot of bit of rosenthal fiber, so that's about gone. Medulloblastoma, definitely, as I said, that medulloblastoma can show Honorite rosette, and it's also synaptophysin positive. That's very important that it is synaptophysin positive, and it's one of the most common malignant tumors in the childhood. Okay, so you want to keep that in mind. It can compress the fourth ventricle, and there's something called as a glioblastoma, and glioblastoma is a grade 4 astrocytoma, and one of the most common, again, malignant tumor, and malignant primary brain tumor that's found in the cerebral hemisphere. It's butterfly shaped and it crosses the two cerebral hemisphere. That is something that you should know, and it's GFAP protein positive, and it's very important is that pseudopalliciding, sorry, not pseudo rosette, it's pseudopalliciding pleomorphic tumor, and that's about it, I guess. Schwannoma is about S100 positive. Ependyma is again found in the fourth ventricle. Obviously, that is also basically nothing. Definitely, an ependyma causes pseudorosettes, perivascular pseudorosette, but that's about it. Pseudorosette basically is Honorite again. So, but definitely, so Honorite is not written. Honorite, it can be written as pseudorosette. Again, that's very high level pathology correlation that I'm trying to get into. But for now, this much is enough. Thank you very much.